All right, Celeste, I'll pull up the slides.
Sure. So good morning, everybody, and welcome to our session on interprofessional education. I hope you all were able to attend the plenary session with Dr. Megan Evans, who was an unbelievable inspiration and made me think I better start learning how to write actual emails to legislators. Um, so we're going to talk a little bit this morning about interprofessional teams and how we can make them more functional for our learners and ourselves and our patients. My name is Celeste Royce. I'm at Beth Israel Deaconess Medical Center. I'm a clerkship director, and I'm a member of the UMEC for APGO. Tara?
Thanks, Celeste. I'm Tara Singh. I'm a physician at Cambridge Health Alliance in Cambridge, Massachusetts. I work with both Emily and Celeste in different ways. I'm a clerkship director and involved in our longitudinal program at Cambridge Health Alliance. Emily?
And hi, I'm Emily. I'm a fourth-year medical student at Harvard Medical School, and I'm applying into OB-GYN this cycle and getting very excited to join this field.
So thank you all for coming today. We're really excited to be here to be able to present this and to meet with you all today. Just to start off, we have no financial disclosures for this presentation. And today our goals for the session are to help you to be able to describe key dimensions of effective teams, and think about interprofessional teams, to help apply strategies to integrate students into new interprofessional teams and sometimes pre-existing interprofessional teams as well, and to think about how to propose opportunities to promote interprofessional learning and teaming among students in obstetrics and gynecology. So for our agenda, we're going to spend some time giving background information about key dimensions of effective teams. And then we're going to move on to a small group discussion where we'll use the dimensions to help build strategies to incorporate students into our interprofessional teams. And then we'll get together as a large group as well to consider barriers and opportunities to fostering interprofessional learning with medical students at our home institutions. And finally, we'll discuss and propose concrete ways to incorporate students into interprofessional learning at our home institutions. Before we get started with our session, we're hoping to learn a little bit about you. And so what we're going to do is we're going to do a poll everywhere poll. So if you have a device that you can use your computer. You can certainly use your phone as well. If you can go to pollev.com/ and then it's tsing500, or you can text tsing500 to 22333 to join. And I'm going to pull up some poll questions here that we're going to do together. All right. So again, that you can see the note at the top, it's pollev.com/ tsing500. And the first question we'd like to know about is, what is your role at your school? And as you complete these, they'll show up on our board here, our whiteboard. We have assistant clerkship director, faculty, teaching. It's all great. All right, thank you. And then our next question is, how many years have you been involved in medical education? So for Emily, Celeste, and I, it's quite a varied amount. Emily, as a medical student, is coming into it fairly new, couple of years. And I've been at Cambridge Health Alliance now for 11 years. And Celeste, what about you? How many years?
I've been here for 11 years as well.
Great. So someone who's brand new, 1 year, and then someone who's been here for 6 and 8. So this is great. Our group is a mixed bag of how long people have been involved in medical education. Thank you. And then, what interprofessional students or teams train at your institution? So we'd love to hear from you what students you have or teams at your institution. And that could be medical students, midwifery students, PA students, even farm students. We have farm residents at our institution. Great. We have residents and medical students, PAs. Excellent.
And Tara, we also have medical student or residents from different specialties too, right? So we can have family practice residents, anesthesia residents, and those are also different ways of thinking about how our teams can be more complex and multidisciplinary.
Thank you. And then we have nursing students too, of course, midwifery. Great. So we have a lot of different types of students that may end up on our service or on our unit or in our clinical space. And we might interact with these students one-on-one. We might interact in groups, lots of different ways for that to happen. Thank you all for completing that. And so just a bit of more of a personal question here. We're interested in knowing if you think at this time and this stage of your career, if you work on an effective interprofessional team. All right, so we have both yes and no. Great. All right. And then next question, I feel comfortable integrating students into the interprofessional team. A lot of yeses there. Oh, and somewhat. Great. All right. And then finally, I provide opportunities to promote interprofessional learning among students in OB-GYN at my institution. That might be in the clinical setting, it might be in the preclinical setting, in whatever fashion or whatever way you provide those opportunities. There's some yes, and some sometimes. Thank you very much. And that's the last of our poll questions for now. We will have another couple of polls. So if you want to stay logged into the polleb.com/tsing500, we'll use that again for our next questions. Thank you all very much for participating in that. All right, so going back to the presentation here. All right. So this is kind of a background picture, which is kind of fun. I love ants because they really do work in teams. They are a true team-based community. And it's always fascinating to me how much they can do when they work together as a team. But we know that our teams in healthcare take on very many forms. There are office-based teams, hospital teams, teams that with a clinician involved, teams that involve patients and or their families. They can be large teams, small teams. Sometimes they're centralized and sometimes they're dispersed. Often they have been for us in person, but now more than ever with the pandemic, we're having virtual teams developing as well. And there's some advantages and disadvantages to that. But regardless of the type of team that's developed and the specific task of the team, there are central tenets that are held by highly functioning teams. And we're going to talk about that today and explore a little bit about that. So I'm going to pass over to Emily now to go forward with talking about our teams.
Yeah, absolutely. Thank you, Dr. Singh. So one framework that we wanted to introduce is the framework of the 5 tribal stages. This comes from a book primarily focused on the corporate world. It's called Tribal Leadership, Leveraging Natural Groups to Build a Thriving Organization. But we actually thought that this framework really applies to a lot of the teams that we work with every day within OB-GYN. And so I'm going to take some time to outline the 5 different tribal stages that this framework presents. And I wonder if you all could take a second to think and maybe even share in the chat if you feel comfortable, which stage you feel like your team is sitting in right now. The first stage, the theme is that life sucks. And this is a network of people that are banded together really for survival purposes. And they may feel like the need to undermine each other, to hurt each other for their own survival, for their own needs. So this is not a safe environment for collaboration. The second stage, it's not that life sucks, is that your life sucks. It sucks that you had to go to work today and work with these people. And, you know, in this network, in this tribe, it's not so much active antagonism, but passive antagonism, where folks might talk about each other behind each other's backs. They might have very low motivation to improve, to work towards shared goals, and to collaborate. Stage 3 is, I think, according to this framework, where most teams sit. This is the idea that I'm great, but you're not. In a stage 3 team or a stage 3 tribe, it's built of highly motivated individuals who are competing with each other to stay on top and to maintain a hierarchy. And the individuals within this team might be reluctant to share their knowledge or their power because that might jeopardize their own position within the existing structure. And so I think that these types of teams are limited in what they're able to accomplish because they're not able to collaborate together. The difference with a stage 4 tribe or team is that they're really able to move beyond that and start collaborating. Within a stage 4 team, you go from I'm great to we're great. The adversary is not just your boss or your coworker, but something greater than the team, and the goals are shared. And those teams are able to accomplish more because they're working together. And then finally, according to this framework, there are a few very visionary and communicative teams that are able to move to stage 5 and really change the world. And I think that within medicine, that's a potential that we have. But a lot of the conversation within this book focuses on how to get from stage 3 to stage 4, which I think is relevant to a lot of our experiences in healthcare. The difference between a stage 3 team and a stage 4 team is that the language shifts from being I to we, and the goals change too. So a stage 4 team is going to draft goals that necessitate teamwork and collaboration. They couldn't possibly be accomplished by just one person. And also a stage 4 team is inclusive rather than exclusive. And I think that's the point to really drive home when we talk about interprofessional communication and learning, especially when we're bringing trainees into the conversation, because a stage 4 team really benefits from bringing in other people and expanding the network and expanding that team's vision. Next slide. Now I'm going to pass it over to Dr. Royce.
Thanks, Emily. So talking about some of the principles of what are effective teams, these are shared not only, as Emily mentioned, in healthcare, but also in other aspects of society. And there are some that are really recognized across the board as pivotal to a well-functioning team. Sorry to use the word pivot after all the chat in the earlier discussion. And these really transcend both homogenous teams, which are, groups of people who have the same backgrounds, but also mixed teams, such as a multidisciplinary or an interprofessional team like we're talking about today. And interestingly, the Institute of Medicine a number of years ago published a discussion of best practices in innovation and collaboration. And they identified these 5 areas as areas where teams who are highly functioning and well-functioning have shared characteristics. So the first thing is the idea that the team has shared goals. Everybody on the team has an understanding of what the goal, the aspiration for that team is. And this in healthcare not only includes all of the members of the different professions on the team, but it also should include the patient and their families, any of their support network, so that we all understand, and ideally are patient-centered about this, what the goal of care for a given patient or given episode of care is. Additionally, there needs to be a clear understanding of the roles of each of the team members so that all members of the team understand the functions and responsibilities of each of the other team members and of themselves, and that they have the accountability. I know what you're doing or you're expected to do. You know what I'm doing or am expected to do. And this allows us to divide the labor up in a way that's not only equitable, but also recognizes if there is a problem, a lapse, if someone is not available to do their job or if they're feeling overwhelmed, our team members can recognize when that happens and step into those roles as needed. The idea of mutual trust, of course, is what all of this is built on, as is effective communication. So having effective closed-loop communication is, again, a foundational aspect of well-functioning teams. And this can be difficult, of course, across interprofessional groups, right? Particularly if there's a hierarchy built into the healthcare system, such as we experience. And that hierarchy can be, of course, experience or age, but it's also societal assignation of what the importance of different roles are, or the perceived importance of different roles are. Lastly, teams should have measurable goals, outcomes, and processes. So we need to know, if we're on a well-functioning team, how we're going to measure if we've succeeded in achieving our goals. We need to have specific check-in points during that process to make sure that we're on the right track, and to be able to give reliable or smart feedback to our team members and to ourselves. So we can go to the next slide there. And these are two groups that have studied healthcare teams in the wild, if you will. And Lorelei Lingard is well known in medical education, and her team noted that interprofessional teams are really quite hard to achieve. And specifically, the finding that they found in this paper was the idea that on teams that are supposed to be non-hierarchical, but that have some hidden hierarchy built into them, physicians specifically felt that the teams were non-hierarchical, whereas others on the team felt, and outside observers, found the opposite. So what they recommended was actually openly recognizing that there are hierarchies on our teams, that these perceptions exist, that there are differences in training and experience, and recognizing and acknowledging those, and yet still empowering everyone on the team to speak up in a democratic way will result in better, more honest and open communication, and better understanding, or better function of the team as a whole. The other group here is this paper was led by Jennifer Weller and the team of Matt Boyd and David Kumin. They've published extensively on effective team behaviors, and that they have found that shared mental models, mutual respect and trust, and closed loop communications are like the basic underpinnings required for effective teams. And they look at the different challenges, whether those are educational, psychological, or organizational, to the development of effective healthcare teams. And they propose 7 steps, and here we go, to improving team communications in order to improve patient and learner safety. And so, as again, the base foundation here, mutual trust, closed loop communication, and a shared mental model of what our goals and measurements for achievement will be. They describe team leadership as being pivotal, and making sure that team leaders understand the roles and recognize when stress is happening for team members. They talk about using multidisciplinary co-teaching models for teams that work together. So any team training that happens should include all the members of the team, not just be for physicians or nurses. And they really advocate using simulation and as high fidelity as possible to achieve that sense of shared mental model. They also talk about using inclusive language, not genderizing any particular profession, but also using terms like provider versus doctor, and making sure that everybody feels welcome on the team. Finally, of course, team leadership is, team champions is critical to success, and making sure that in your department or your leadership roles, that they buy into that system of interdisciplinary teams, and that they invest in those teams in a functional way. So as we can see here, all of these circles overlap, and that not one of them is more important than the other. All of them are equally important, but they're built on these foundations of the shared mental models, trust and understanding, and communication. So we can go to the next slide. And this is our poll. And so we want to know what people think about what made them want to be part of their teams, and perhaps specifically in the setting of OB/GYN, in the OR, on labor and delivery, in clinic. What might have made you feel inspired to be part of a team? Interesting, autonomy. The idea of being part of a team and yet being able to function in your role. Patient care. I think looking back for myself, I think I really aspired to be someone who had the knowledge and leadership skills to be part of a team. And wanting to learn those was motivating for me. I don't know, Dr. Singh, anything to add to that?
I think, yeah, absolutely. I think the inclusiveness of the team too, but feeling that I could say something and it would be heard by the team. Maybe it was right, maybe it was wrong, but I found that that was very valuable to feel part of the team.
And I think for me as a medical student, when you show up and people are expecting you to be there, they welcome you, they know your name, and they remember it, that means more than I could possibly say. And then also having a specific role that's for me and feeling like I have something, even as a medical student, to contribute has felt really important.
Thanks for sharing, you guys. So I think we can go to the next slide.
So I know that we've introduced some frameworks and have talked about some research within this topic, but we really hoped that this presentation would be useful and practical. And the way to do that, I think, is sharing all of our ideas with each other. I know that we have a group here of folks, and if you would feel comfortable turning on your videos and participating in our conversation, we would be really interested in hearing your perspective when it comes to some of these questions. The first thing that we wanted to talk about is the strategies that we might use to incorporate learners into our teams. And so, given the number of folks that we have here with us today, we thought we could just all have one big conversation where we're using the key dimensions that Dr. Royce mentioned: team leadership, mutual performance monitoring, backup behavior, adaptability, and team orientation, to think about what we can do to incorporate learners into our teams every day. And also, if everyone who's here just wants to take a second to introduce themselves, we'd be really interested in who's with us today.
I guess I'll start. Can everyone hear me?
Yes.
Hi, I'm Courtney. I am an assistant clerkship director at East Carolina University with Dr. Jill Sutton.
Oh, wow.
And it is, yes, it's great working with her. I just started in April, so pretty new to this, and I just graduated residency last year, so new to everything. And I guess that's about it. Are we just introducing ourselves right now?
Yeah.
Yeah, that would be great. I also see Megan Valentine here with us. Would you feel comfortable saying hi?
Yeah, hi, I'm Megan Valentine. I'm at Carolina's Medical Center in Charlotte. I don't have I'm leading the GYN AI currently, but I was previously the clerkship director at GW University for 5 years as the assistant or the clerkship director. So in my new role here, with no more official position in the educational realm.
Great, thank you. And then how about Sylvia Sussner?
If you can't get the audio to work, you can just throw it in the chat too. I have certainly had that happen to me in the last 2 years.
I can see that you're not muted anymore, but I still can't quite hear you. I don't know if anyone else can.
Not yet.
Well, that's okay. Sometimes these things take time to work out, so we can have a conversation both out loud and in the chat, and that'll work really well. Perfect. Thank you both so much. It's really nice to meet you both.
And Emily, I don't know, can you see the chat there? So Sylvia is from Albany Medical Center, New York. Thank you for sharing that. And we have Dr. Nguyen, who is from Santa Clara Valley Medical Center, taking over for Dr. Wilma Lee as Medical Student Clerkship Director at the site in the fall. Welcome, everyone.
Well, thank you all so much for being here and for sharing your ideas so far. And we would just love to hear, the strategies that you are using or that you're thinking about using to better incorporate learners into your teams.
So currently for us at East Carolina, what we do for our third year students, speaking specifically on labor and delivery, it's a little bit easier to talk about that. They round on our antepartum patients with one of our senior residents. So they'll see patients individually, will write their own note, and then they present to our MFMs during those rounds. And after our antepartum rounds, which are kind of separate with the MFMs in the morning, they joined the team, a little bit mid-morning or so with the senior resident, and then they split up our laboring patients, and each one will follow during cervical checks and deliveries and C-sections. They'll see triage patients and everything. But I am, I guess, interested in just how other people incorporate their students. I feel like one of the challenges that we're having is we also have off-service residents, and then we have AIs as well as, I guess, having enough, work for everyone to do to feel like they are a meaningful part of the team, as well as from, I guess, incorporating liability issues, as well. I think that's one of the fears with how much, our teams allow the students to do. Personally, I feel like when I was a student, I enjoyed when I had a clear role and when I felt like what I did mattered, and I feel like some of our students, feel like they write notes, but the residents are writing notes as well. And so no one really reads their notes. It doesn't really matter what they say, and I would like to get them a little bit more involved in the team. So just curious as to how everyone manages, so many different learners and everything in the same space.
And Dr. Nguyen says that they have the medical students present the laboring patients at sign out. So the students are participating in sign out actively. So even if they aren't able to write notes in your system, and I know some people have that as a problem, having students be active as members of the team in other ways can go a long way towards making them feel welcome. As you mentioned, Dr. Strickland, one of the things that's just most valuable is when you feel like you're needed or you're making a contribution to the team. And so anything that we can do like that helps our students to feel more welcome, I think will go a long way.
Yeah, thank you so much for sharing that. It sounds like you've already made some strides to create clear roles for your students, but you're also pointing out some of the very real tensions that exist when there are trainees of multiple levels and multiple disciplines who are all working in the same space and might have different needs and different abilities to contribute. And then also how difficult it is to provide someone with a role that feels useful when there, can be a lot of redundancy sometimes. I think you can say that.
Yeah, we're definitely working on it. It's not perfect, but that was some of the feedback that I saw in the GQ from some of the students. I think that, um, and I will admit, I think it depends on the student. Some of them are a little bit more enthusiastic, and so the ones that are, I think, do get a little bit more from the rotation. But I would say in general, I think from me asking them, they would appreciate having a little bit more autonomy, or just a little bit, more to do. But I am struggling, I guess, with dividing up the work between, our residents as the trainees, as well as our off-service residents, which we can have, we'll have 4 labor and delivery residents, 2 to 3 off-service residents, um, you know, 3 medical students, as well as potentially an AI, depending on the time of the year, and only a certain number of patients. And then, you have patients who, for whatever reason, don't want to see, medical students, which is their right. And then you have, patients who are dealing with loss or grief, sometimes, it seems like there's not always enough to go around.
Do you separate, or do you have students in for overnight call or anything like that, or on weekends?
Yes, we do. But they don't do 24-hour shifts, so
Yeah.
they're either there in the daytime or at night.
Yeah, I think with the pandemic, one of the things that we did was we went to having students working 8-hour shifts. So they come in
Hmm.
with the residents in the morning, but they don't stay at the whole resident shift. They leave at about 2:30 in the afternoon. And then another student comes in at 2:30. And actually, the student will sign out the board to the next student. And that we have what we call a teaching attending. We ask that the teaching attending watch that sign out to give them tips on how they can do it, so that it's kind of like parallel play with what the residents are doing in real life, right?
Gotcha.
What the residents are doing is the actual work. The students are kind of doing it parallel, but they really that way feel like they've got some ownership, that they're actually helping each other and doing some peer teaching as well. And then we have one student
Mhm.
who comes in for 3 nights out of a week for an overnight shift. And so the student that's there for the 2:30 to 11 shift signs out to the overnight student. And that's actually been working really well, and that limits the number of learners that are in the space at once, because there's only so many patients
Yeah,
to go around, right?
great. That sounds like a good idea. And I'm in my mind, I'm thinking too, we probably need to incorporate a little bit more work, I guess, with our attendings that are there. Unfortunately, I think what kind of just happens is a lot of the responsibilities just tend to fall on the residents, and they're already busy, as we all know. And and I mean, we're all busy. All of us are. Even as the attending, when I'm working, sometimes I feel like I'm trying to manage all these different patients, so it's hard for me to sit down and feel like I can, have one-on-one time with students. Um, so just trying to, see where we can, um, I guess, all be a team and collaborate, and have take care of our patients, but then also have effective learning as well.
Yeah. One of the things I think we've noticed at our institution too is that the nurses are great teachers, especially if the student is hanging out in the room with the patient. So one of the things that we've started to do to help the nurses be aware that our students are coming along is we send an email blast once a week with nursing updates that go to the whole department. They go to the nurses, the midwives, the PAs, the physicians, everybody gets it. And we'll put the pictures of the students coming in that flyer, that email, and so that the nurses are aware that there are, and not just the nurses, but the whole team is aware of the students coming, which can be helpful. And we've done 2 bio cards as well. We've had students actually create cards that talk a little bit about themselves that have been presented to patients, but we've talked about that. We haven't implemented yet on labor and delivery, but we've talked about what if the students created these that we could put up on labor and delivery or put in that bulletin once a week so that the rest of the team can know who's coming along, just as an introductory way before the students get there.
That sounds good. I think that'd be a good idea.
Yeah, I can say from my perspective, I've been in an environment that had my face on a card that every patient got. And so I was part of, at least from the patient perspective, I was part of the team from the very beginning, and they were, expecting to see me come in the door. And then I think that spoke a lot to the idea, that it kind of translated throughout the team that I was a part of them too. I know we've already touched on so many things that we were hoping to get to, of course, in the presentation. I wonder if we just want to keep kind of advancing through our slides as we continue this conversation.
Sure.
I'll just pull them up again. And thank you all for sharing as well. Emily, I'm going to move on to the next slide.
Yeah, thank you. So we've already touched on this, how different types of trainees have different needs, and how it can be hard to provide for all of those and adapt to all of those in one day, especially when everyone's really busy. So we were just going to take a minute or two to throw out some ideas from anyone for the different types of activities that might work well for our different types of trainees, because there might be some overlap there, or there might be some differences. And so we've already talked about how medical students can be useful in sign out, how they can follow a patient through their labor course. Does anyone have any other ideas for how medical students and PA students can be useful or be integrated into our interprofessional teams? And feel free to write in the chat too, if that's easiest.
Tara, I think that your site probably has the most different types of learners in this, particularly on labor and delivery. Do you have any specific ways that you get these teams to kind of coalesce and have meaningful roles for all the different learners?
I think, thanks, Celeste. I think we do have a lot of learners. We have PA students, we have medical students, we have midwifery students, nursing students, family medicine residents, and OB residents, all on a community unit, labor and delivery unit. And students change, sometimes every 6 weeks, residents every 8 to 10 weeks, and some residents are just there for a month. So there's a lot of turnover. I think what we've tried to do as a whole group is come up with activities that we can make sure that the trainees can be part of. So great chatting about labor and delivery and signing out patients or presenting patients at rounds. Those are all things that we've considered. Simple things such as even following up on postoperative blood tests. So the hemoglobin that's coming back from the C-section patient on postoperative day 1, having the student follow up on that and report back about whether that is normal, abnormal, what we would need to do next. Our nursing and NP students, we all take an active role in teaching all of our students, which is nice. Our nurses teach our medical students. We help teach the nursing students. With the nursing students, we sometimes work on lines, even Foley catheters, because those are skills that they need to get. And the nurses are always appreciative when we can help out with our nursing students or NP students for that. And then, of course, from a resident perspective, and our midwifery students, from a resident perspective, it's all about where the resident is coming from. And I think one of the things that our team really tries to do is have a conversation at the beginning of the rotation with the resident to see what their level of experience is and what their goals are. I think sometimes as a medical student, you have no idea what you want to get out of it. But as a resident, this is going to be an area you're going to work in. So you might actually have ideas about, I'd like to achieve this during my time on the unit. And so I think having those conversations is helpful to help the residents forward their goals and their learning objectives.
And particularly, I think when you have residents from different backgrounds too, like family practice, midwifery, OB-GYN, like they may all want to get something else out of the learning experience. Family practice, they just want to get those quick deliveries, right? Whereas the midwifery students may too. How do you help students and learners to navigate what might be a little bit of competition, like Dr. Strickland was talking about, for clinical experiences?
Right. So that is trickier for sure. But it's always great to watch an OB resident take a family medicine resident or a midwifery student through a delivery while you're still there, and actively involved, but you give them that responsibility and you teach them how to do that before you go into the room, obviously. We have had luck with students pairing to take care of a patient. So we have had patients be willing to have two students be there as part, and then one of them might take a more active role in delivering the baby, maybe one in delivering the placenta, or the other student could also be part of the pediatric team looking at the baby as the baby's born, doing the APGAR scoring, and helping with that. So sometimes pairing has been helpful if you have patients who are willing to take on more than one trainee.
And from my own experience way back when, we were taught mainly by the midwives, honestly. And so making sure that your students understand that other professionals are there and have skills and knowledge that the physicians may not, right? And so, for example, we have our students now rotate for half a day with a nurse shadowing them in their role on labor and delivery. And that's been really nice. It just highlights the different roles and how it really is a team taking care of the patient, not just the MD and not just the nurse.
Yeah, and I would say as a student, some of the most valuable learning exercises for me have been, for example, the opportunity to go through everyone's fetal heart tracing and kind of for me to work through that in real time. But also, even if no one has time to teach me, I've really valued my role sometimes as patient expert, being told by a resident or a physician or a midwife that they are working on something right now. They don't, it would be really helpful if I could go check in on a patient and learn what's going on with them, what's most important to them. And that's been a role that I've really valued, even on a really busy floor. So thanks everyone for your thoughts there. We can keep moving through our presentation.
All right, Dr. Royce, this is you.
Yeah, so we were going to talk a little bit about what barriers people find to fostering these ideals of interprofessional learning and teams for our medical students in particular. And we've talked a little bit about some of the barriers. Here's another case that has both barriers and perhaps some supports in it. And we were talking earlier, and Emily asked me, or said, oh, where'd you get these cases? It's like, oh, I just thought back to the last 2 weeks of my personal life. But the first case is a team meeting on labor and delivery. It's scheduled for 10 a.m. And the people who are expected to attend are all the nurses, the midwives, anesthesia, both attendings and residents, OB attendings, OB residents, and then the nursing and medical students are all expected to be there. Everybody's paged ahead of time to meet at 10 o'clock. At 10:03, the nurses are all there, the medical students and nursing students are all there, the resource nurse is there. There's one anesthesia resident and one of the 3 OBs. None of the MFMs are there. The resource nurse begins the meeting and kind of mutters under her breath, those 2 doctors, X and Y, or X and Z, are never on time. At 10:04, 2 of the OB residents show up and the MFM doctor shows up. But the meeting is interrupted several times during presentations of the patients by the unit clerk who calls or who's interrupting with calls from patient rooms asking for nurses' assistance. So I think we can all appreciate the difficulties that are here in this scenario for how we can, or how interprofessional learning might happen. If anybody wants to talk about the barriers that are here, but also what the supports are in this system for improving interprofessional learning. And then the last question is, what changes could be made to the team meeting to support interprofessional learning and to improve the team dynamics there?
So I can start. So it seems like some of the barriers are just expectations to be on time to a meeting and the importance of being on time to that meeting, as well as some of the like expectations for the clerk who's calling from patient rooms asking for nurse assistance. So expectations that, what is appropriate to call for and what is not, what can wait until the meeting is done. So I think clarifying those two things would help with a more effective sign out or meeting. But I do think some of the things they're doing well is who they're including. So it is a multidisciplinary meeting, which is really important to effective patient care.
Yeah, thanks, Megan. I agree. There's the idea of having a team meeting is really important. And in our institution, it's the nurses who present the patients across the board. So it takes a little bit of pressure off of the learners, the medical students and the residents. They're not expected to present the patients. And it hopefully helps to level the hierarchy a little bit because the nurses are the ones doing the presentations and clarifying any questions that the team may have about patient care or the status of a patient. And it models this idea for our learners that everybody does have an important voice in the team, and we are able to communicate across disciplines in an effective manner. I should say also that we embrace SBAR as a communication technique. So situation, background, assessment, and recommendations. It's, as you all probably know, it's taken from nursing and actually military communications, but it's really effective for cross discipline and interprofessional communication because it is such a succinct way of communicating a lot of information quickly. Any ideas about changing how we could make this better? Megan mentioned, making sure that our expectations are correct, or that we have a shared mental model as to what that is, and then making sure that we do have to set aside time that's dedicated to communication. Again, just thinking about the role of leadership within that, so that there is communication to everybody on the team as to what those expectations are. Anything else that people can think of that might make this a better situation?
I guess if the other two, attendings are never on time, either addressing it to see if it's an expectation issue where they didn't think they needed to be on time, or is it that this time for the meeting actually never works out with their schedule due to other responsibilities, and should the meeting just be moved to a different time to accommodate them?
Yeah, absolutely. So recognizing what the pressures are outside of the team, and this gets to the idea of understanding what the different roles and functions of people on the team are. So if the attendings always have a staff meeting that goes from 9 to 10, they're always going to be late to a 10 o'clock meeting. Well, maybe that, as you say, changing that time, but that involves everyone on the team acknowledging that there are different roles that we have outside of our teams, and where those stresses might be that we can fix. We could maybe go on to the next case. So this is an ambulatory case. A colleague emails you about her niece, Samantha, who's completing nurse practitioner school. She needs to get her ambulatory gynecologic experience to complete the women's health track. And you agree to have Sam in your office with you for 4 hours every week. Initially, it works well. Sam is well liked by your patients and your office staff, and she's recognized as one of the providers. She comes in every Tuesday afternoon. She sees about 3 patients. Her workups are thorough. Your only feedback for her so far is that She's a little bit slower than you might like, and she tends to follow a checklist. She doesn't think a lot, very deeply about the diagnostic process. And the clerkship director contacts you and asks you, would you be able to accommodate a student in your office as well? You say yes, and your staff schedules both Sam and the student, Charles, into your Tuesday afternoon sessions. So how many of us have had that happen? You have two learners show up unexpectedly. Charles is quick to see is quick to see patients, and he makes decisions about care easily, but he doesn't really gel with the staff. He has a little bit of a standoffish attitude when they try to engage with him in conversation. So how can we, in this kind of situation, foster a better learning environment for both Sam and Charles? How can we perhaps get our staff to be involved to help with this? And what are the opportunities for interprofessional or peer learning or teaching that might help to improve the team dynamics for this team that's been thrown together somewhat unexpectedly?
So I think in these situations, and we had this at GW a lot, setting very clear expectations for the providers about how many learners we would ideally want them to have in clinic at a time. Most faculty don't want two students at the same time because it's very challenging and really helps with efficiency. So letting faculty, for at GW, we almost always had a medical student in our faculty clinics. So having outside learners was really not something that we accepted or encouraged for that reason. But if you do have the ability, making sure that whoever's scheduling those knows that putting them on 2 different days is most ideal. And then just setting expectations for your staff about what the student is capable of doing based on their skill level. So the NP student might have a very different skill set is going to have a different skill set than a medical student, and also different expectations for what they do and don't do with the patients, how many patients they see. So just setting those expectations up front. And then I think making sure that there's good, like having, you guys said, having cards for the student, a nice introduction between the student and the staff, as well as the student and the provider they're working for, can really go a long ways in terms of fostering those relationships.
I really like all of those ideas. And we all know that good communication with our staff is key to having a successful clinic. Any other thoughts about how we can make this better?
Celeste, in our clinic, our medical assistant rooms the patients. And so what we will do is at the beginning of the session, we'll have a huddle. And there's, as you said, times when 2 students show up. So it'll be the medical assistant, the 2 students, and myself, and we'll go through the list of patients for the session, and we'll put initials or names by the patients that we're hoping the students will see, so that everybody has a clear picture of who's seeing whom. And so they can read the charts on the medical records, so they can review ahead of time. And then the medical assistant knows when they're going in, they can say, oh, Sarah will see this patient and Jennifer will see that patient. And so they know what the expectations are as well. I find that sometimes that helps, especially for the medical assistant.
Yeah, absolutely. And we do that a little bit also. I tend to assign patients to a learner. I kind of handpick which ones they should see. And I also ask the medical assistant to help with that process as well, because sometimes the medical assistants know the patients better than we do, right? Dr. Nguyen says, introducing the learner to the staff and emphasizing to the whole staff that everybody, or emphasizing to, I guess, the learner, how the entire staff plays an important role in patient care. I like to say that I think that the hardest job is the front desk, right? They're handling the phone calls, they're handling the angry patients, they're the ones that tell patients how long the wait is going to be. All of those things are really tough to be on the front line, and sometimes students really don't appreciate that. Just they don't have the situational knowledge yet. So I love that idea of making sure that both the learners understand the staff's role and the staff understands the learner's role. Emily, do you want to talk at all about peer-to-peer or near-peer teaching?
Yeah, I guess going off of what you were just saying, Dr. Royce, I've been in a lot of outpatient clinic settings, often with Dr. Singh, because I was at the community hospital where she works. And one thing that I've really appreciated is the opportunity, even through a structured activity like a scavenger hunt, to make sure that on my first day in a clinic, I am meeting everyone that works there. I'm meeting the front desk person, the nurse, the medical assistant, and even asking them to just chat with me, for 5 minutes about what their job is and what they like about it and how I can be supportive to them and also learn from them as a medical student. There have been a couple of times in my education where those activities have been part of my experience in a clinic, and I've really benefited hugely from that. And then I know we're already coming up against the end of our time, but I'll just say in terms of near peer teaching, I really enjoyed being a sub-intern this year as a 3rd and 4th year medical student, and have enjoyed the times. I'm sure this is tough on the attending, but where there are two of us together, and we're able to say like, okay, Emily, you've had a little bit more experience. You're going to go see this patient on your own while I go in with this other student who might be a 2nd year or 3rd year. And then when you come out, you're going to present to both of us so that you're not only presenting to the attending, but to the other student. And then, I've also offered as a more senior medical student to have a more junior medical student present to me first and give them my thoughts before they go and present back to the rest of the team. So I'm sure it's stressful when there's so many learners in one space, but I've really enjoyed that.
That's awesome.
Thank you, Emily. So we have just about 5 minutes left. So we're going to just sort of wrap up a little bit here. And we're going to think a little bit about opportunities that exist to foster interprofessional learning and teaming with medical students. And hopefully some of that has come out of today's discussion. We wanted to review some of the things that we are actually doing on an interprofessional level at our institution. And I'm happy to provide more information about this if that is helpful to you outside of this talk today. Celeste already mentioned this. At both of our sites, we do RN shifts for the students. So our students on labor and delivery actually have a shift with the nurses on the unit. And that allows them to meet the nurse and sort of understand what their role is and to really understand how integral a part they are of the team for taking care of the patient. Also, our first year students at Harvard Medical School are doing student-patient interactions where they sit down with the patient and they have a conversation about the care providers on their team and what does it mean to have an interprofessional team take care of you. So from the patient perspective, so they have some time where they talk to the patient, maybe a cardiology patient, about the cardiologist who's involved, but also the nurse who's involved and the technicians who are involved and all the players and how the patient understands the roles of the different players taking care of them. And then as they advance into their clinical year, our medical students have the opportunity to have a discussion with a professional of a different profession than medicine. So it could be a social worker, respiratory therapist, even a midwife. And they have these conversations. They are managing a patient with this person, and they would have this conversation at the end of the encounter to see how it went, talk about what things work well interprofessionally and what things can we continue to improve upon. And I put the card down here on the bottom right, showing the different types of providers and OB-GYN that our students might encounter. On the back of that card, the students actually write down a couple of points about how that encounter was with the professional and what they learned. And the professional actually does the same on the back of the card. And then at either mid or end of rotation for OB-GYN, our faculty, our clerkship directors, assistant directors will actually review with the student those experiences and just delve a little more into what does it mean to be part of an interprofessional team, so that the students are thinking about that as they're moving forward into their final clinical years and then eventually into residency and practice. So really trying to build steps and build ways for students to understand interprofessional care early on and then continue to develop it over the course of their medical school training. So as we think about all the care providers and we think about who teaches whom, I'm going to show you there are so many different ways that we can engage with our learners and our trainees. We learn from each other, but our trainees also learn from all of us and for all of those of us who are on labor and delivery and have the opportunity to work with them. So we can draw arrows, and this looks very messy, back and forth from all the different providers. But one person that we often forget is our teacher. is our patient. And our patient really, we put the patient at the center of the interprofessional care team. We can learn an awful lot from our patients about how to care for the patients. So just to keep that in mind too, our students, our residents, our team can learn from our patients. So having had this talk and this discussion, hopefully it sparks some ideas about things that you can do to help integrate trainees into your team. And if you would like, we would love you to put into the chat one thing that you think you will do going forward as a result of this workshop today. One thing that you will try to implement or add to your arsenal of things to integrate your trainees into your team. If we did this in person, I would give you a card and I would have you put your name and address in the front. And I would mail it to you in a few months. Since we're not in person, I'm going to ask you to put it into the chat, put your email address, and then I will reach out to you in 3 or 4 months, maybe around June, and see how are you doing? Were you able to integrate trainees into your team with your proposal, with how you wanted to do it? So do feel free, if you'd like, to put that in the chat, and I'll make sure to reach out to you at the end.
And our room is going to close very soon, so if you don't get a chance to do that, you can always hook up with any of us through the Whova application through the rest of the conference, and we look forward to continuing the discussion offline.
Thank you. Thank you all for attending today.
Thanks.
Great talk, guys. I need to close the room so we can move on to the next one. But as you said, just keep checking the Whova app and for connections. And Celeste, you know how to make a discussion like we did for CD School yesterday. So that would be a good idea too.
Awesome. And can you capture the chat, or do we need to do that?
No, I'm going to save that too.
Okay, great. Thanks.
Thank you.
Bye.
Bye, guys.